So are you still very much a part of the MAC?
No, I pulled out of that so that I could refocus on everything, because that was getting with the monoclonals. It was really kind of sign of exploding.
Yeah.
It started to take up a whole lot more time after it had kind of settled down quite nicely.
Right.
But then reasonably so, everybody being focused on it, which is what we wanted. And then, but everything on the behavioral health side continues to be, grow and expand, especially in light of everything that's gone on with COVID. So I asked to be pulled off of that so I could just divert my energies in-house.
Yeah,
so.
Same. It was a big change of pace, like coming back here after it was I think it was 7 or 8 months I was detailed, and then coming back it was weird at first, and now we're back in the office. We're in 3 days. Is BHA 3 days, or
we are kind of catch as catch can?
Yeah,
so
right.
Yeah, we're trying to we're trying to do this in a way that is supportive of the workforce, and also accepting of the reality that most of our meetings are still virtual, particularly at the more senior levels in my administration. So, to come into work and spend your entire day in front of your computer, is there, how much utility is there to that? So we're just trying to be flexible. I think that once the case rates come down really, really well, I think it'll be easier, and people will have more desire to kind of get back into the office more regularly. But in the meantime, the most important thing is just making sure everything is getting done, which it is.
Exactly.
Bi-monthly meeting, and I think I had this conversation before that I feel that bi-monthly means every other month. Some people think it means twice in the month. Okay, but it depends on how. Meeting of the commission to study mental and behavioral health in Maryland. Of course, as everyone can see, we're here at Towson University, here in beautiful Baltimore County. And of course, keeping with local guidance and the rules here at Towson regarding COVID-19 precautions, we are wearing masks indoors. So we appreciate everyone's cooperation. Our last meeting was done, well, at least our last virtual meeting was in May This commission heard from the county's police chief, Melissa Hyatt, and Dr. Gregory Branch, the county's, Baltimore County's Director of Health and Human Services. Chief Hyatt and Dr. Branch explained how the Baltimore County Crisis Response System provides intervention services for individuals in crisis. It was extremely informative for us, and I think many of the members of our commission agree that it was an enlightening conversation. This afternoon, County Executive Johnny Olszewski is gracious enough to join us, and I'd like to invite him to share his greetings and tell us more about any initiatives that are going on in this great county. Thank you for being here. There's a mic there. Or, yeah.
Well, thank you, Lieutenant Governor. Really appreciate the opportunity to join you in the commission. I want to commend all the incredible work that you all are doing. You already had the rock stars of Baltimore County and Chief Hyatt and Dr. Branch, but happy to just give greetings and thank you for the hard work that you're doing to raise awareness and tackle the issues of behavioral and mental health. Obviously something that we take very seriously here in Baltimore County, and knowing the impact is only expected to grow in the wake of the pandemic. In addition to the initiatives that Chief Hyatt and Dr. Branch mentioned last meeting, we're taking the opportunities we think about recovery and the American Recovery Act to invest additional resources in Baltimore County so that mental health and behavioral health issues remain a significant issue that we are tackling. So last week we did announce that we'll be using significant funding from the American Rescue Plan to stand up new mental and behavioral health resources. For us, that includes hiring additional social workers to support our residents, providing mental health first aid training for the public, providing trauma-informed customer care training for public-facing county employees, and expanding resources for domestic violence coordinators and vulnerable adult coordinators. We're also taking steps to look internal and better support our employees as well. We will be hiring a wellness coordinator for Baltimore County and developing a wellness app for career, volunteer, and retiree firefighters alike. In addition, we're planning to launch a two-part public service campaign to encourage primary care practices to screen for mental health symptoms and encourage residents to get a mental health checkup. Again, as was shared with you last meeting, we also plan to use some of these recovery funding dollars to support the expansion of that mobile crisis team, as well as hiring of clinicians for the first time standing up and being inside of our 911 call center. We're also actively working with our regional partners here in Baltimore County to support mental and behavioral health. In Baltimore County, we're proud to have Sheppard Pratt, one of the nation's leading psychiatric hospitals in the country. And we were proud to recently partner with them on their. It is one of the first of its kind partnerships with local governments to create that hub and spoke model to expand access of care and improve health outcomes for individuals experiencing opioid addiction. We were proud early in our administration to also open the first residential treatment in Baltimore County at the Rosewood campus. And we know that we will continue to work with partners like Sheppard Pratt, like Towson University, and with our state partners to continue expanding access and services. So again, I just want to welcome you again to Baltimore County. Thank you all for your time and talent commitment to this important effort. And just remind you that as you continue your work, we stand ready to continue being a partner with all of you in the days, weeks, and months ahead. So thanks again, Lieutenant Governor, and to all of our commission members.
Thank you.
Appreciate the
Thank you
opportunity.
very much, County Executive. Appreciate your taking the time to join us, and engage today on mental health. The pandemic has affected, everyone, not just in our state, in our country, in the world, quite frankly. And we know that it's had an impact on students. So I was just talking to the president, and she was saying that typically a large percentage of the kids that just come onto campus come in with a diagnosis of some sort. And it's been, of course, exacerbated by the pandemic. The sense of isolation, the anxiety has been a particular challenge. And so I think the timing just to have it on campus I think at 4 o'clock, probably a lot of the students are going and having lunch or something, or doing what students do. No comments on that. But, I just want to highlight the fact that, Towson has been helping its students as they face mental health challenges, mental and behavioral health challenges, and sometimes feel overwhelmed. And I know Mollie Herman is here. Yes, Mollie Herman, the interim director for the Towson's Counseling Center is here. And Ms. Herman, I think you're going to add something about what you're doing here on campus.
Thank you so much for having me. I really appreciate this opportunity to talk about what we offer at the Counseling Center, since we are tasked with supporting the mental health of all Towson University students, which is a heavy lift, but we're really excited about the work that we do. So to tell you just for a few minutes about how we operate, we actually had a major overhaul of our clinical services system right around the time the pandemic started, which wasn't planned to coincide with the start of the pandemic, but that's how it worked out. We used to have just kind of a full psychosocial intake. People would wait sometimes 2-3 weeks to get an appointment, and then they might not be able to come back for 2 to 3 weeks. And that understandably was not a system that was working very well to support the mental health of our students. So we now have what's called a flexible care model, which is something that many college counseling centers and university counseling centers across the country are looking to. What we offer now is same-day service. So that's the big headline. Students call, the day that they call, they can come in for an appointment that very day. And that's so important, particularly when they're on a semester schedule. A couple weeks difference can mean the difference between a successful semester and a semester that they really can't succeed at. When they come in, they meet with a counselor, and we offer a culturally responsive, customized plan for them. We have a wide array of options that they can choose from. That's another thing that we did, is we expanded the types of service that we offer. Many students, of course, want that ongoing individual counseling, but there's also many students who don't really want that. They want something, they may want peer support, they may want online resources, self-help resources, group therapy. So we have a much more comprehensive array of services that students can choose from, and empower them to figure out what it is that they need based on their own unique mental health circumstances. We also offer a full array of substance abuse treatment services, assessment and treatment. We have a recovery community. We have a health educator on substance abuse issues and peer education program, so that students, of course, listen really well to other students, maybe more so than they listen to staff. So they're a very critical part of getting our message out. We also just recently partnered with an organization called Protocol, which allows us to offer 24/7 support. So as soon as our phone lines go off for the day, then when somebody calls our number, they're automatically connected to a counselor, to a clinician who can provide crisis service, can help them get connected with, if they need to go to the hospital, can help facilitate that and provide guidance to concerned others. So that's a really wonderful service that we've been offering also pretty much since the pandemic started. Another real wonderful initiative that we have is called Together All, which we're one of the earlier adopters for universities in the United States to use this program. It's something that started in Europe. It was used widely in Canada, and now they're starting to become more widely known in the United States. It's a digital peer-to-peer support platform. So all Towson students have access to it. They can create an account, and 24/7 they can log on and find discussion groups. They can do artistic endeavors. They can take self-help courses. So that's another really wonderful service that we are very proud to offer. And the SGA of Towson University is sponsoring it financially, which is a real wonderful initiative. So there's a lot of student buy-in. We are also lucky enough to be a JED campus. So JED is a nonprofit organization that was started by the parents of a college student who died by suicide. And it's a suicide prevention organization that partners. It's a 4-year partnership that they do with universities. The first year, which we've completed, involves a baseline assessment and a campus visit where they assess what are all the different systems in place to have the safety net. With the counseling center, can't do it all. And a university that's going to really provide comprehensive safety net to all students, it means that we need to have everybody on campus involved and aware of their role and how they can be helpful. So JED has created a strategic plan for us, and we're doing a collaborative endeavor with campus partners to build over the next 3 years to build up some of those suggestions from their strategic plan. And then one last one last initiative that we've just recently started is Cognito, which is another online resource, which is to train. There's two versions, a faculty and staff version, and then a version for students to give people the skills to talk to students in distress. And particularly, I know when I go around and talk to faculty about how to identify students in distress, how to support them, that when I share with them, if you're getting an indication that somebody may be feeling suicidal, it's really important to directly ask them that. Are they having thoughts of ending their lives? And faculty often will, their eyes get really big and they feel very anxious for understandable reasons. Cognito actually provides an interactive simulation training on how to have those conversations, and people get to choose responses and then get feedback, either, yeah, that was a good way to go, or you might want to rethink that, and some explanations as to why. And the student that they're interacting with responds accordingly. So it's a fun training, and it's one that there's a lot of evidence to support its effectiveness. So we're really excited about these additional initiatives that we've just added in the past year or two. And we also always do a lot of prevention work, outreach programming. We've been doing this both virtually and in person. We're very active on social media. We know where to find the students. So Facebook, TikTok, YouTube, Twitter. That's all stuff that I don't really know that much about. But fortunately, there are people on our staff who are experts and who are really elevating our profile in that respect. So that's kind of an overview of our highlights. Are there any questions that I can answer for anybody?
I have a question in terms of, you mentioned the being able to speak to someone on the telephone, a counselor, and having the other service that when your phones go down, it automatically goes. What is the volume of calls that you're getting?
So that's varied a lot from month to month, and there's a crescendo happening right now. We're getting
close to finals?
Midterms.
Okay.
Yes, close. That certainly we tend to see a peak around now. I'm just ballparking it right now because I haven't seen the recent report. Maybe 30 a month.
Okay, that's pretty high though.
Yeah, it's high, and we actually sometimes we have a baseline that we pay for that may be like 30 a month, and then we have to pay overages for above and beyond. And we have had a couple months where we've paid those overages, so there's a big need for it.
But most of the calls come in after hours then?
Those would be the ones that go to that service.
Yes. Right.
Yeah, but we get many calls during the day that we field ourselves. Okay. So those I can't tell you the number, but I can tell you that we're hopping.
Yeah. Do you classify your calls differently? That some are, not as critical, and some seem very critical or serious?
We used to do that more clearly, because when we had that system where students had to set up an intake that might be a couple weeks away, then we would say, if somebody's in crisis, then they would come in right away. Now that we have same day service, all we can do is say how many students are coming in for same day service.
Right.
But I can tell you that we have a weekly meeting where we as a group, we discuss students who are in our risk management system. We have an evidence-based system that we use, that students who meet certain criteria are monitored by the whole staff through consultation. And this morning we had 15 students that we reviewed in that meeting. So that's just for this week. So we are certainly doing a lot towards managing students at risk. Yeah,
and you have over 20,000 students? Yeah,
I think it's about just under 24,000.
That includes graduate level?
Yeah. The much larger undergraduate population than graduate, but yes, we do have a graduate student at school as well.
Any questions from? Oh yeah.
So I'm very excited to hear about all the things that you're doing. It's fabulous. The suicide program. What did you say the name of that was?
Do you mean Cognito?
No.
JED, the JED Foundation.
JED.
Yeah.
JED.
JED. Yeah, that was.
You said dead.
Oh,
I thought that was going to be a really strong message.
No, I'm so glad you clarified. No, it's JED. That was the name of their.
Scratch that part out.
Yes, don't write that down. That was the name of their son who died by suicide.
Got it. Thank you.
Any additional questions?
Thank you for your amazing work. How many counseling staff do you have?
So I should know that off the top of my head, shouldn't I? It's kind of a moving target. We have approximately 16 or 17 psychologists, and then we also have 4 doctoral interns, and we also have some externs who are at a lower level of training, and we have a few master's level clinicians. So our entire staff is maybe close to 20.
Did you see a higher demand with the pandemic?
You know what? We actually saw almost zero demand during the pandemic year, which we're seeing a higher demand now.
Oh, that's what.
Yes. Excuse me. Yeah, the pent up demand is coming out. We were seeing people remotely during the pandemic year. We did so much outreach and so much effort to try to get people to call us because we knew they really needed help. And I think it was sort of an out of sight, out of mind situation. So yes, we were worried about the pent up demand, and we are seeing that now.
In July of 22, the National Suicide Hotline will be available, 988. Are you planning on transitioning your calls to that, or are you going to keep your calls intact within your program?
Probably a yes and yes both. We will certainly be listing that as a referral option and make sure that people have information about that. But the service that answers the calls for us is particular for Towson. They're customized. They know about all the resources that we have on campus. They fill out a report for us that we at the counseling center are able to see the next day. So that's more of an in-house service, but we will certainly widely advertise that hotline as well.
Any other questions? Thank you again. Thank you very much.
Thank you so much for having me. Thank you for all your good work too.
No, thank you for what you're doing. Okay. Well, as everyone should know, this Thursday, November 11th, is Veterans Day, and as most people do know, it was once Armistice Day. The 11th hour, the 11th day of the 11th month, ended the First World War, and a day for celebrating, of course, and honoring our nation's veterans and their patriotism and their willingness to sacrifice for all of us. According to a study that was published by JAMA Psychiatry, nearly 1 in 4, unfortunately, active duty members have shown signs of a mental health condition. And I wanted to take this opportunity to ask, and we're honored that she accepted to come here. Brigadier General Janine Burkhead from the Maryland Army National Guard is joining us today. Last month, General Burkhead had invited me to a wellness and resiliency training in Annapolis for the Maryland National Guard, their recruiting and retention battalion. And I had the privilege to interact with our citizen soldiers there to discuss the importance of them prioritizing mental health, and especially what we have been asking of the National Guard over the last 2 years almost now. And during today's meeting, you will hear from Donna Bowie, a licensed clinical professional counselor with experience working with individuals with a range of mental and behavioral health concerns, including military families and members of the military. And I look forward to hearing from her today. The state of Maryland, of course, we're committed to supporting our veterans and in their mental health journey. And our military veterans and their families, members who live in Maryland can sign up for Operation Roll Call. And Operation Roll Call provides weekly and sometimes twice weekly check-ins, or every other weekly check-in for the individuals who sign up. And they can do so by calling 1-877-770-4801. And we'll put that on our website as well. Of course, anyone who's experiencing a mental health crisis can call Maryland's crisis hotline, which is 211, and press 1 to get help immediately. Of course, there is a suicide prevention line that is available 24 hours a day, 7 days a week, and that is 800-273-TALK or 800-273-8255. And so these are resources that are available. And of course, if you're a military veteran joining us today in person or online, I want to thank you for your service. Thank you for your dedication, not only to our great state, but to the United States of America. And so now I'd like to transition to our formal agenda at this point. And I guess we should start with the introduction of our commission members. And I know some are coming in remotely, the value of technology. So maybe we should start with, well, I guess I'll go with the Let me just ask, does red mean that they're not here, Heather? Okay, then I won't. Okay. Delegate Kelly? Maybe it's better if we just go around the table. We'll start with Ms. Delegate Young.
Hi, good afternoon. Delegate Karen Lewis Young from Frederick.
Good afternoon, Mary Ann Gibson, Deputy Director of the Opioid Operational Command Center, here for Robin McCard.
I'm Barbara Allen. I wear many hats. One primary I'll speak to is I chair the Howard County Opioid Crisis Community Council.
Good afternoon. I'm Mary Gable. I'm Assistant State Superintendent with the Maryland State Department of Education. In particular, in that division, we work with student services, and mental health. I also have to make a plug. I'm the commissioner for the Interstate Compact for Educational Opportunity for Military Children. So I represent Maryland. All 50 states plus the District of Columbia have signed on. I'm happy to assist in any way this transition to military families.
Good afternoon, Tiffany Rexroad, the Assistant Deputy Secretary for Programs with the Maryland Department of Human Services.
Hello, David Coody, Associate Commissioner for Life and Health, Maryland Administration.
Good afternoon. I'm Dr. Linda Vineski. I'm the Director of Mental Health for the Department of Public Safety and Correctional Services.
I'm Carrie Guthrie-Cho, President and CEO of Cornerstone Montgomery, a behavioral health nonprofit in Montgomery County.
Good afternoon. I'm Tricia Roddy. I'm the Deputy Medicaid Director.
Good afternoon. I'm Richard Abbott. I'm Director of Juvenile Family Services for the Maryland Judiciary, and I represent the Judiciary Commission.
Can we go to our members who are coming in virtually?
I'll go first. Aaliyah Jones, Deputy Secretary for Maryland's Behavioral Health Administration.
Hey there, this is Pat Medashevsky. I am a patient advocate, family advocate, and a registered nurse. And thank you for this opportunity.
Hi, I'm Serena Eckwood, and I'm with NAMI, Prince George's County, and I'm also a family advocate as well.
Good afternoon, Christian Mealy, Deputy Secretary of the Department of Disabilities and co-chair of the Youth and Family Subcommittee.
Quickly go to the minutes, but you all have not received the minutes as yet because we started a new process for producing the minutes. And actually, it's a good process, but it's extremely detailed. So we just have had a chance to really review and make some edits to it today. So we'll be sending the minutes out to everyone in the coming week, and then do an electronic or probably an electronic vote to approve the minutes from the last meeting at that time. So I just wanted to point that out so that no one gets disappointed that they didn't get a chance to read the minutes from the last meeting. But I have, and they're very enlightening, but it's a lot more detailed than the minutes we've had before. So it will take you time. I think it was somewhere around 9 pages of minutes, single space. So it's a little bit of detail. So, okay, we will turn to the subcommittees now. I guess we can start with a report from the Crisis System Advisory Work Group.
Good evening. Thank you for the opportunity to present on behalf of, can you hear me?
Dr. Jones, I think you're still muted. At least we're not hearing.
Can you hear me now? Okay, great. So good evening. Thank you for the opportunity to share an update for the Crisis Services Work Group and all there's a huge amount of work that's going on with this crisis, with this work group. I'll start with just informing you that we had a large meeting on October the 19th where we had a presentation about utilizing peer recovery supports in crisis services. If you look at the sequential intercept model roadmap, it was pointed out to us several areas in the community that are best supported or best suited for peer support, which include warm lines and crisis line operators, providing resources to individuals who are accessing these call lines, providing outreach to individuals who have recently experienced overdose and or suicide attempts, and to family members to offer supports and resources, including naloxone training and connecting people to local recovery resources in the community, and facilitating support groups and one-on-one peer sessions that develop recovery capital for individuals seeking or maintaining their recovery and wellness. And so we continue to be committed to utilizing those with lived experience in the behavioral health system of care, including in the provision of crisis services. We were happy to announce that we have received some additional funding to our mental health block grant from ARPA, and we're going to be using this funding to, amongst other things, but to support the development of a behavioral health urgent care center in a region of the state where no such care centers exists. And so we're going to be funding $1.3 million over 4 years to support the development of an urgent care center in a rural area of the state. We are posting a notice of funding availability on the Behavioral Health Administration website in mid-November. So again, that goes in line with the development or growth of the infrastructure for crisis services throughout the state. We also have additional funding that we're going to be using to the tune of $800,000 from the BHA Mental Health Block Grant to support the development of a care traffic control center in 2 different counties, one in Southern Maryland and one in Western Maryland, in areas that demonstrate need, capacity, and capability, however, are not currently being funded through the HSCRC Regional Catalyst grants. So again, building the infrastructure for expansion of crisis services, and also looking to expand crisis walk-in centers and behavioral health urgent care centers. We have $4.7 million that we will be using towards expanding the utilization of peer recovery specialists within these centers across the state. Our best practices and standardization subcommittee continues to work on the HB 332 or designated psychiatric emergency facility legislation, and expanding. This legislation expands the criteria about who can be eligible as a place to receive a person on an emergency petition, including outpatient mental health clinics. And so we have been working most recently on discussing the criteria for adequate staffing to help those in crisis, including peer supports, to ensure that these alternate sites are able to care for people in a safe way, regardless of the time that the individual presents for care. We're also looking at standardizing definitions for crisis services across our crisis service system, but also crisis services within the child space. And the reason why this is important, and number one, is just so that we are all using the same language, but then also once you have the same language, then we can look at the types of services that are covered under each of these different types of programs. And that will be necessary from a standardization of implementation of these various programs so that we can get the support that we need for funding for these types of services to be funded through Medicaid. And to move from a grant-based model of funding for crisis services, which is one of our primary goals. Our sustainability subcommittee is reviewing a newly published cost of care report, which was completed by Maryland's Medicaid. I'm using the Crisis Now model to look at recommendations for what is the cost of care for providing crisis services, how much needs to be available to ensure that the crisis needs for individuals across the state can be met. We applied for a planning grant that was approved by CMS. We're using those dollars to support the expense of having a vendor with our landscape, helping us to do our landscape analysis, and also helping to plan out what the infrastructure needs are for the state of Maryland to adequately meet the crisis needs of our citizens across the state. Our 988 subcommittee, as was already previously mentioned, during this meeting, that 988 is going to be replacing the 1-800 number for suicide prevention, and the calls are going to be routed by the first 6 digits of the caller's phone number, which is a bit backwards for the state of Maryland, in that our 211 system, 211 press 1, actually connects people to call centers based upon the cell towers that they're closest to. And so it's a more precise way of getting people connected to call centers and therefore to resources for care. But nonetheless, 988 goes live next summer. We have submitted, the Behavioral Health Administration submitted an implementation plan to Vibrant Emotional Health, which is a contractor for SAMHSA, which administers this lifeline, with 3 areas of focus. We'll be focusing on funding and what the funding needs are to handle the presumed increase in volume of calls, the capacity, and ensuring high quality 24/7 response. We are concerned about changes in the quality of the service that will be delivered due to the increases in volume, and then also coordination with 211 Press 1 and other local call services and warm lines that need to be integrated with 988. We submitted a request to use our ARPA funding to support calls associated with call, text, and chat volume increases, and we have gotten approval to use $3.9 million through September 30th, 2025, which is going to be distributed to our call centers on a formula derived from fiscal year 21 volume reports, so that we can get ahead of this transition and try to ensure that there is some maintenance of quality of service that's going to be delivered once this transition occurs. Our data subcommittee is reviewing a comprehensive list of data elements from a number of resources, so that we can ensure that that when we get to the position to collect data around crisis services, that we are collecting the best information, the best data. We participated in a crisis conference last month, a number of BHA team members did. And there's lots of different ways that you can look at and lots of at the data and lots of different data elements, but which are the ones that are most critical, that are going to give you the best information for the management of the system, are what we are going for. And lastly, our Child and Youth Subcommittee is working closely with this data subcommittee so that we can also ensure that we are collecting some standardized information on our children who present for crisis services, again, with the idea of better having an idea of what the needs are so we can better meet those needs and continue to develop our crisis services system. And we'll be working with the University of Maryland on a crisis and stabilization landscape analysis of our crisis and stabilization services. And we're going to be doing more with providing training on screening tools and data collection elements and general technical support starting in December of this year, and then more broadly in 2022 to other jurisdictions, focusing in the beginning on our early adopters, and then also doing some refreshing training on some specialized screening tools for children's crisis needs. And our next stakeholder work group meeting is scheduled for December the 14th. And we look forward to bringing you the next report when next we meet.
Dr. Jones, thank you very much. How are you feeling? I know you've been a little under the weather.
Oh my goodness, under the weather first, and then we got COVID. So coming off of my quarantine, and I'm feeling great. Thank you.
Okay, well, a real practitioner, you decided to, experience COVID yourself. So
I'm saying, some of us have to learn the hard way. We got caught by daycare. It was going to happen eventually.
Youth and Families Subcommittee. I think Christian Mollie is there. I see him.
Good afternoon, Lieutenant Governor. Sorry, I was on mute. Good afternoon, Lieutenant Governor, fellow commissioners, participants in today's meeting, and County Executive Olszewski. Always good to see you. Sorry I can't be with you in person this afternoon at my alma mater, Go Tigers, but I'm pleased to present today's report on behalf of the Youth and Family Subcommittee. The subcommittee held its standing meeting yesterday afternoon, and we were the beneficiaries of a really comprehensive and excellent presentation from our partners at Montgomery County's Local Behavioral Health Authority regarding its expansion of crisis services. The focus in Montgomery County really is on a few different pillars and principles: 24/7, 365 response, community-based first response, which minimizes police engagement in some cases, 100% access, a multidisciplinary team response, including peers, trauma-informed care, and care coordination. And their model also includes an integrated regional call center, mobile crisis and outreach teams, a stabilization center with crisis care follow-up, and a number of other features, which are all features that we as a subcommittee, commission, and the state can be looking to as part of our analysis of best practices in our 24 jurisdictions. I would be happy to share with anybody interested this presentation. Just let me know and I can send that via email. The Youth and Family Subcommittee is eager to find ways, and we spent a considerable amount of time talking about this yesterday. We want to ensure that children, youth, and families are considered foremost and on an equal footing with adult services when we're developing as a state and building out the continuum of crisis care across Maryland. And we spent a lot of time weighing our options in this regard. We also discussed actionable goals for our 2021 recommendations, which include one recommendation in particular that I'll discuss today, and that's related to the accessibility of information connected to available services and resources online. So that recommendation, as stated in our recent report to the full commission, stands to improve access for Maryland's youth and families to vital information on mental health and substance use disorder websites managed by the state, and also to expand community outreach and education by doing these three things. One is the use of clear, concise language and infographics. When we were sort of comparing Maryland sites to some of our sister states, Maryland has some really great information, but some of it seems to be a bit text heavy and content heavy. So we think that we can make it easier to find what people are looking for, especially in crisis situations, by having call outs, infographics, probably less text, and the use of different web-based techniques to draw attention to the services that are available. That would include the use of video regarding resources and services, living with mental and behavioral health issues. And also a big pillar of what we're looking to do is ensure accessibility of electronically based information in conformity with all state and federal laws, including the Americans with Disabilities Act. So regarding that outcome in particular, one real way we can make an impact for users with disabilities is to ensure that that my agency's new IT accessibility coordinator, Andrew Drummond, he's been just terrific. He's been working with partner agencies across the state and with some of the locals as well, testing mobile platforms, both on iOS and Android desktop applications to ensure their accessibility. He's certified by the International sort of Best Practices Board for the accessibility of IT products, vendor products, and information. So we're really excited to have him on board, and I think he would be well suited to sort of partner with the state as we roll out this particular recommendation, which hopefully may be accepted by the full commission in due time. The subcommittee's next scheduled meeting is January 10th, 2022, scheduled from 1 to 3 p.m. Although there was some discussion yesterday about spacing out our meetings a little bit further from the standing meeting of the full commission. So we're sending out a doodle poll to our over 20 members to get their feedback and support on that call to action. So with that being said, that's the report for the Youth and Family Subcommittee. And thank you everybody for the opportunity to make that presentation.
Thank you, Christian. So I guess the question is, was your time at Towson so colorful that you've been banned from campus? Is that the reason?
I hope not. You have to tell Professor Batts I said hello. I saw that you were speaking in his persuasion class. He was a good friend of mine when I was a student there. But no, I worked there for 4 years, so I hope they didn't ban me. Since then, after I graduated, they hired me in the student affairs division. So before I stumbled into law school and then public service, I was working in higher ed. So I do miss being there today, though, and I hope you all have a great time at TU.
Okay, thank you. No, it's just messing with you a little bit. That was low-hanging fruit. Okay, the Financing and Funding Subcommittee.
Met last November 2nd. We're in the process of scheduling the next meeting. From the Medicaid perspective, we talked about 3 areas during the meeting. First of all, we talked about that we had gotten back together the behavioral health system of care integration and optimization work group. Again, this is the goal of this work group is to better coordinate care between our behavioral health, ASO, Administrative Services Organization, and our Medicaid MCOs. So we've got those meetings scheduled, and we're on a regular cadence with those meetings. We're in the process of working with the work group to develop a list of projects that they think would be beneficial for improving the system of care. And we're in the process of picking and selecting 2 or 3 of those projects. A couple of examples of some of the projects that we're discussing is improving the data sharing across the 2 systems. And then also better improving the screening, briefing, and intervention and referral tool called ESPERT. So that's where you identify and refer individuals for substance use treatment. So we spent a lot of time discussing those 2 projects, but again, there's a whole range of additional projects that are being considered. Secondly, we talked about Medicaid's 1115 waiver amendment or renewal application that's in front of the federal government right now. Again, in that renewal application, we applied to cover and receive federal dollars for adults who are between the ages of 21 and 64, so that we would receive federal matching dollars while they're receiving services in what's considered an institution for mental disease. Just wanted to let everyone here know that those discussions with CMS are progressing and they're moving along very nicely. We do expect that it will be in our terms and conditions and that the program will be effective January 1st, so coming this calendar year. And then thirdly, we talked about the monies that have become available to Medicaid in the American Rescue Plan Act. So within the act, Medicaid is able to get some additional federal dollars for home and community-based services during a certain time period. Those additional dollars are available to us between April 1st of 21 through March 31st of 22. Those additional dollars that are accumulated need to be reinvested back into the program. And we have until March of 2024 to complete that reinvestment. The legislature directed us last year to spend 75% of those dollars on a one-time rate increase for qualified providers. I'm happy to announce that that one-time rate increase went into effect November 1st. So for those behavioral health providers that qualified for the rate increase, they got 5.4%, a 5.4% rate increase. Again, that went into effect November 1st. Now we have to figure out what we want to do with the remaining 25% of the dollars that will be accumulated and how we're going to reinvest that back into the Medicaid program. We've developed a process on our website where we are taking stakeholder input. They have until November 15th to provide ideas to us, which we will then consider and then report back out to the stakeholders, as well as include it in a spending plan that needs to be approved by the federal government. So we're looking forward to everyone's great ideas and taking those into consideration. So I'll turn it over to David Cooney to give the second half of the report, and then, of course, answer any questions if you have it.
Sure. Thank you, Tricia. So I'm going to have a brief update for the private insurance network advocacy focus area, particularly our mental health parity reporting regulations that we've been working on. As we mentioned at some of the prior commission meetings, we did expose a pre-publication draft of the regulations and the template reporting forms over the summer with a deadline in early September for written comments. We received those comments, we reviewed and considered all of them, as well as oral testimony we've received. And then we made further revisions to streamline the regulations and also to clarify certain requirements there where it seemed to be some confusion based on some of the comments we received. So the formally proposed regulations were published in the Maryland Register on October 22nd. We also posted revised template reporting forms and instructions on our website on October 15th. And we convened a public hearing just last week on November 1st to discuss the proposed changes. The main topic of discussion at the public hearing was the data supplement forms that we developed to be standardized supporting documentation to go along with the reports. For some context here, when a mental health parity analysis is performed to determine whether non-quantitative treatment limitations or NQTLs, whether they're applied comparably to mental health and substance abuse and medical surgical benefits, there's two phases to the analysis. First, you examine all the written policies and procedures to make sure that they're applied comparably. And that's called an as-written analysis in the federal regulations. But then the second phase of the analysis, you're really looking at in practice, are these limitations applied comparably to mental health and substance abuse or not? And the federal regulations call that the in-operation phase of the analysis. So we feel very strongly that these data supplements we developed, that they're critical to complete the in-operation analysis, and the consumer advocates have been very supportive of these supplements, but the insurance carriers, on the other hand, have been very opposed to the MIA requiring any type of specific data points that have to be reported. The insurance companies have noted that implementation of these standardized data supplements that we developed are going to be very costly and resource intensive. They also correctly point out that the federal MFIA regulations don't actually require plans to collect data in a specific prescribed way and would allow plans to submit their own data points to support the analysis. So based on those discussions, we are allowing an additional 2-week period for comments and the data supplements before we make a final decision and finalize those regulations. I also wanted to touch briefly on workforce issues related to behavioral health that have been mentioned in a couple of the last couple of meetings. So at the MIA, we've been thinking of what we could possibly do to help in this area. Unfortunately, we do have a limited ability to address workforce issues directly, since we only regulate the insurance companies, don't have any direct influence over the actual medical providers. But the one area where we think we do have something to offer is we are able to investigate any potential violations of Maryland laws governing credentialing of medical providers to get into insurance providers' networks. And really, if you think about it, any credentialing barriers that hinder providers from joining insurance networks, that can act as a disincentive for certain providers in certain specialties to want to practice in Maryland. So if we address these issues, it may at least indirectly help with the workforce situation. And along those lines, I want to highlight that we just recently had a complaint investigation that did result in the MIA issuing an order against United Healthcare Insurance Company. United Healthcare had refused to credential certain licensed master social workers in violation of Maryland law. And this was a law that was specifically revised in just 2020 to allow more social workers to participate in insurance networks. So we're trying to do everything we can to just continue to encourage providers to file complaints with us if they feel that they've been unlawfully denied credentialing in insurance companies' networks. Because that's the only way we can be aware of those problems. Then we can investigate and make sure they're complying with any applicable laws. And, that concludes summary for the private insurance area.
Okay, thank you. Tricia, I have a question, and I think you discussed it last time as well as today with regard to that one-time Medicaid rate adjustment. And I believe maybe Delegate Young had asked about how, if it's a one-time, is it a rate paid this year and then it goes back next year unless we, then the state picks up the rest of it?
So our reinvestment commitment goes out to 2024. So that 5.4% rate increase assumes that our reinvestment goes out to 2024. There is no end date to that 5.4% rate increase. So, essentially, it will stay within the baseline.
Okay, so, but does that mean that that's cut back on their contribution to that?
No, it'll be matched at our regular rate.
Oh, okay.
So, if it was a 90% rate or a 50% rate, we get our regular match. We also get the additional 6.2% federal match that we're getting during the federal pandemic under Medicaid. So it follows the same matching that would exist for other services.
Thank you. Okay. Next, we're gonna. Oh well, I don't know. Are there any questions with regard to those reports? Any questions? Oh.
Thank you.
Delegate, thank you.
I have a question for Ms. Roddy. I work with a number of caregiving groups, in particular those caregivers who provide services for individuals with developmental disabilities and those caregivers that provide services for individuals with Alzheimer's and other forms of dementia. As I'm sure you know, they have been inordinately affected by the pandemic in terms of support resources. Should either of those groups be interested in applying for some of those federal funds, where should they direct their request?
So the Developmental Disabilities Administration also got monies went in for a rate increase. They got 5.5% rate increase that was 5.5%. The legislature directed the remaining funds for the 25% under the DDA administration to be spent on provider grants. In our spending application, there's $50 million that will be non-competitive going to providers and 10 million that will be competitive. There's some parameters around what the providers can spend it on. And we've been meeting extensively with the stakeholders to better understand what the provider needs are. There's been surveys, et cetera. I'm happy to meet with you afterwards. They can obviously go on our website and fill out, how they would like to spend the plans, but I'll put you in touch with the DDA administration so that you can speak with them directly on that.
Thanks very much.
All right, well, thank you, everyone. Now we're going to be having a presentation. I'd like to ask Brigadier General Burkhead. Oh, I'm sorry. Was there another question? I'm sorry. Oh, how come I missed that? Okay, sorry. I checked it off too quickly. Public safety. Excuse me, General Burkhead. Thank you. I am sorry about that. I just jumped. Okay. Skipped is used to old records and phonographs.
Quiet. I think Senator Hester would be, my co-chair, Senator Hester. Good evening. At our last Public Safety and Judicial Subcommittee meeting on October 12th, we hosted a panel of guest speakers on workforce development following discussion from previous commission meetings and stakeholder experience with labor shortages. We heard from Denise Gilmore, the field director of for American Federation of State, County, Municipal Employees in Council 3. Denise presented on challenges in the correctional system in Maryland faces in recruiting and retaining mental health employees. Samantha Scott, Kelsey George, and Kelly Hughes from the National Conference on State Legislatures. Samantha presented on the policy overview, and they provided on background, behavioral health services and correctional settings, state actions to address behavioral health workforce shortages. Nationally, mandatory overtime, work overload, competition from other fields, stigma, lack of opportunity for professional growth, compensation and benefits all contributed to the growing issues of staff shortage and high turnover within this field. The subcommittee identified non-competitive salaries as a challenge to recruiting and maintaining staff in the correctional facilities, particularly with mental health professionals who have opportunities within other systems and, of course, private practice. NCSL shared Kansas as an example of the impact of salary increases, a 2.5% to 7% increase in salary for correctional staff, decreased uniform staff vacancies by 75%. We also discussed licensure requirements at the cost of renewing professional licenses for mental health professionals can be burdensome. Several states made licensure changes during the pandemic to decrease the cost and otherwise modified licensure requirements in the field. And then our next one, I'm going to skip this part of it. We're running pretty good. We're holding our next meeting on December 14th. And
I just apologize for almost skipping past you. So thank you. Have we seen, and this is broader than the mental health professionals and substance use disorder professionals, have we seen a uptick in correctional workers after the governor put through salary increases, at least in the applications?
No.
Do you know? Okay.
No,
I know it's a challenge for
correctional officers, but I'm sorry, Mollie Herman left. I wanted to know how she had 16 psychologists on her staff, and I have 5 vacancies. So I was like, wow.
So you're going to poach them. So okay. So yeah, well, I guess it's so much competition, and maybe people want to work with kids, or not kids, but young adults more so than in a correctional facility that they have that.
I think you have to look at the correctional system as a public health, and you have to want to be able to deal with that kind of system
Yes.
versus the freedom of doing telepsychology, going to a counseling center. It's much different. And you have to look at it as a public health crisis type of work.
Okay. All right. Well, thank you as always. Okay. And now, Brigadier General Burkhead, if you can introduce this special presentation from the Maryland Army National Guard Mental and Behavioral Wellness, Health Wellness Program.
Let me see if you want to go ahead and take your place while I'm introducing the team. So the Maryland Army National Guard is 4,600 strong. And I have here with me Brigadier General Adam Flash, is the Director of the Joint Staff. But specific to the behavioral health team, I have Major Faith Corville. You'd stand, raise your hand. She's the Deputy State Surgeon. I have Mr. Sean Branson, the Resilience, Risk Reduction, and Suicide Program Manager. I have Staff Sergeant Ashley Ritter, State NCO for Trauma. And then I have Sergeant First Class Newer, Master Resilience Training Program. And so this makes up the core team along with the leadership. And being 4,600 strong, full-time and part-time, it makes a difference. You would think that the soldiers and the employees that we have with the Maryland National Guard would go to their full-time places where they go, their family and their friends. But they're with us part-time, and you'll find that they seek us out for their behavioral health issues more than one would think. So at the cornerstone of the work that we do, I have to give credit to what we call Miss D, Dionne Bowie, Miss D, because Miss D is that 24-hour go-to, and I don't know what we would do without her. So I have to give her props for being that stalwart piece in the cog that keeps it working. And so you can't poach her. But so today she's going to give you some of the background about what we do and how we do it and why we're so successful as a team. And so with that, Ms. D, you take it away.
Thanks. Thank you for having me. And I don't know how far I can walk. I'm not used to standing behind a podium. Usually I'm in an armory and I'm moving around quite a bit. So give me a moment to get used to actually being behind a podium. Again, I am Ms. D. A little bit about me. I have never served in uniform. A lot of people ask that, so I'm going to let you know up front, I have never served in uniform. However, my husband was active duty for 26 years. And my father was a Marine. And if you know anything about Marines, they still are Marines for 22 years. So I was born into this. I was meant to stay in this. So this is why I do this job. It means a whole lot to me. So I'm very passionate about it. So as I talk about it today, if I sound passionate about it, or I look like, oh my gosh, it is because I really feel it all the way to my core. So I don't know how to make my slides come up. So forgive me. Oh, look, there we go. Okay, I'm on fire now. All right, so our agenda, I'm going to talk about what our mission and vision is, the support that we give to our soldiers, how we recognize the problems, the holistic approach that we take, and it is really a holistic approach, so I might stay on that for a second. The resources, help-seeking factors, reducing stigma, and my favorite topic, resiliency stand down. So that's what we're going to cover. I'm not going to read to you, but just as a gist, our mission is to execute a holistic health effort to definitely get after all of those high-risk behaviors while giving them a wellness and holistic, not just for our service member, but for the entire family. We're not just looking at our soldier. We know that there's a soldier, but we know that there's something more. So we go after the whole unit. And when I say the whole unit, I mean the whole unit, the family, the unit, the brigade, the battalion, everyone. So that is our thing. And we're getting ready. So getting them ready for whatever it is. And I know for the general and everyone else, some of our soldiers come in and they're coming off these campuses. They're coming out of high school. So we're getting them ready. So, we're getting them ready for whatever it is. And I want to make sure that they're ready holistically for what that is. And how we do that, we focus on resiliency. I know the last 2 or 3 years, our soldiers were like, oh my gosh, are you here to talk about resiliency again? Yes, I am. Risk reduction, suicide prevention. We have an entire suicide prevention program. And our commanders, this is new to us. So we have our new CR2C, which I'm going to tell you I'm excited about because it's going to be this way that we get to be innovative. We are already innovative, but now we're going to be innovative together, all in one room. So the CR2C is going to be the commander's readiness force where we're all going to bring our everything that's happening inside of the Guard, the National Guard, and we're going to talk about it in one room and talk about how we're going to prepare for it. And we're doing it now, but now we're going to do it in a much better circumstance. So I'm really excited about the CR2C. Kicks off in January. So the things that we see in our service members, and please know that some of the service members bring these things with them. Not all of these things are related to the military. They didn't join us and we did this to them. Some of these things are pre-existing. So we're looking at depression, suicide ideation, anxiety, PTSD, alcohol abuse, substance abuse, relationship conflicts. All of those things are not just Guard things. I want you to remember that our Guard members are, I think I heard you say earlier, they are citizen soldiers. They very much are. They are in and out of boots. So some of these circumstances that we see aren't due to just Guard things. A lot of the phone calls that I get are things that are happening in their civilian lives, and they bring them to the Guard. And yes, and sometimes there are things that happen in the Guard that they take to their civilian lives. So it can be a very big thing, but not all of it is due to us. So how do we help? Whew. I believe in a holistic approach. If you know anything about mental and behavioral health, to me, it's like a stacking process, right? As he heads nodding, it is very much a stacking process. I had a talk last week at Morgan State talking to the students, and I was talking about what causes stress. And they were saying, oh, but my financial aid didn't go through. So well, that was one thing. And then we start talking about the next thing. And it's very much a stacking thing. And the same thing happens with our soldiers. So I want to make sure when they come in and we're doing that assessment on them, that we're hitting every avenue of what's happening. And then as the National Guard, we've been very good at providing supports for everything that you see on that screen. Everything on that screen. I can tell you yesterday, personally, I made sure that a soldier got health care and then got treatment today. So everything you see on this screen, we take care of or find resources to do it for us. We have two types of soldiers. We have our AGRs and our traditional M-Day. I'm not going to speak strongly on that because I don't know a whole lot how to define them, but as you can see on our screen, the M-Days are our weekend warriors. So they're only coming in 1 week in a month and 2 weeks out of the year. And then we have our AGR, and they're like our active duty soldiers. They're kind of full-time. You see them all the time. So right now, assigning have 4,634. My phone number should be in every single one of their phones. I know. And then for the active Guard, there are 466 assigned. So who's calling me and what are they calling for? So this is for the 2019 FY 2020. I want you to remember that, there was COVID. So we had a moment where things were a little bit slow and then things picked up. Attempts, we had 3. Ideations, 15. Ideations were people calling saying, I'm thinking about killing myself. This is a thought, sort of have a plan. I may not always have a plan, but this is definitely an idea in my head. And we had to get them to a hospital and get them help. So there were 15 of those that came up to us. We have 64 people enrolled in our substance abuse program right now. Behavioral health, this is considered me. And I want you to remember when you look at the calls, I had 1,434 phone calls. That's first contact phone calls. That doesn't mean me calling them back or them calling me back. That's just first contact phone calls. The first time they called me, and I record that it's a first contact phone call. So there were 1,434 of those. I had 614 text messages. And in person, there were 151. So of course, a total of 2,199. What's missing from there is the virtual, because we switched over to virtual somewhere in that time, and I don't have my virtuals recorded for you, but in there we started doing our virtual. So that's how many soldiers we touched as far as behavioral health phone calls. And financially, getting them enrolled and helping them out, 1,159 soldiers that we gave some type of financial counseling to. All of these people are our resources in the Guard. The ones that you see here, the resilience, risk reduction, and suicide prevention, they said there's a thing called our MRTs. It's based on CBT type of therapy, and it has 14 different structures that they talk about. And they go out to our units. We have MRT trainers, and they talk about resiliency and how to train. It's a very good program, and our soldiers learn from that. We have our unit risk inventory. It's very much anonymous. They get to sign and tell us what's going on with them anonymously, and then I get those results back, or other people get those results back, and then we put a plan together to talk about those results and put a plan in place to help them. They have chaplain support. They have our community resources that I'm partnering with all the time. We have gatekeepers within the unit. They have their family support. We have our medical support. Our medical support has been so brilliant over the last, especially during COVID. I can tell you this weekend, especially during PHAs, our doctors are actually walking them down to my office. They talk to them, and if they say anything about being stressed or anything about needing a service, or it has just been a little bit difficult, I actually have doctors saying, you know what, Ms. D is here, or we have a behavioral health officer in the building. Let me walk you down and get you a service. So even our medical professionals are being helpful. And then, of course, our unit leadership. I can't tell you enough about our unit leadership right now because I'm on the phone with commanders day and night, and they look out for our soldiers. More, and I think I spoke to most of these, but this is definitely all of our things that we have in place right now, helping our soldiers out. So I'm not going to read this, but I think some of the helping factors that help our soldiers reach out for help, and I thought about this a lot when I was like, oh, I have to come here and talk. And what I got to tell you is that when I took this job and they were saying like, we have to, it's yours, figure out how to make this work. And I've been in a lot of different industries doing behavioral health. And I remember thinking, I'm going to make friends within the Guard and outside of the Guard. And what we've done is we've made mental health approachable. We've made it so that we just talk about it. When soldiers are in there, they talk to us. It is so approachable. We make this, we have these things in place where you can do it informal and formal, and it's integrated, and we're supportive. But that last part, the supportive, trusting environment, I have to tell you that in the last 2.5 years, we have built this environment that is so supportive and trusting for the National Guard. There, I have soldiers that call and say, Ms. D, my battle buddy. I have commanders that call and say, what can we do? Our environment is so trusting. And if I could do anything for the entire world, it would be to give them a taste of what the National Guard is feeling right now for an environment. We do have to provide accurate information because there is still a fear out there. When they call, they say, what's going to happen to me? I have a secret clearance. I still want to be promoted. I don't want to leave my unit. What's going to happen to me? One of my things is like, we're not looking to get you out of a uniform. We want to help you the best way we can. So let's deal with getting you well first, and then let's go back. So we look at all the ways that we can do that. Some of the things that we look at now is that some of our soldiers, even the ones that have had some issues, I have 2 soldiers that I think of off the top of my head that have had issues with substance abuse. We got them the treatment that they needed. One I saw this weekend, he came in and he's telling me how wonderful he's doing. We're a year out of treatment. He's still in uniform. We supported him every step of the way for him to still be in that uniform. The other one, he is not only in uniform, but we're working with the state where he's going to be doing other things to help out and be a peer support. So part of it is learning how to be this environment where we can be so supportive. We also have SAPR, and we use acronyms, but that's our sexual assault program. We have restricted and unrestricted reports. So our soldiers who are sexually assaulted, male or female, they have the right to take those reports and they can be restricted where they don't have to, they can tell us what happened, but they don't have to have any actions brought against it, or unrestricted where actions are brought up, but they are still allowed to have mental health care. This has been a great program for us to, and they even have, there's a new computer program too, but I won't go into that. But all of it is, we are supporting every single member no matter what they need. How we support them, we have all kinds of great things. I'm a little all over the place, but those 4 things, the after action debriefing, critical incident education. I think one day you came and we did the skill debriefing. All of these things are important because, and I want to make sure I stress this, everything is done according to the unit. So it's like how you do an assessment on a patient, we do an assessment on a unit. All those other things that I talked about, they're important, but what's even more important is that we go into a unit and we do an assessment that URI that's taking place, all those other things that take place, just like we do an assessment on a client, we do an assessment on a unit, and we find out what's happening, what's the heartbeat of the unit, what's happening in the unit, what does this unit need? And then as a team, all the people that stood up, other people that work within the guard, we put together like a treatment plan for that unit, and we make that happen. So it's like a unit is actually getting behavioral health care, which is an amazing thought when you think about it. But we actually provide that for a unit, every unit that comes back and needs something. So it's not just the individual, but actually a unit that can get care too. And we do it through these debriefings and skill sets. We have the stand down, which I got to tell you that I love because we have to find a way to maintain. So even though we're doing these other briefings and other things, we have to maintain this, right? And if COVID taught us anything, maintaining is important. So how we're maintaining is through the resiliency stand down. This year, Sergeant Noor and I discussed how we're going to do that. And we're going to put a wellness spin on it. And so our resiliency stand down has become important. Over the last year, we did this major stand down where every single unit came in. Again, we did a huge assessment of what that unit needed. And then we went back out and they were able to go back and put in practices for that unit. They had many job fairs. They had different people come in and do things for that unit, such as, counseling or whatever that unit needs. This year, we know that there needs to be a wellness focus. Our phone calls are up. There's things that our units need. So this year, we're looking at a wellness focus for all of our units. And that's what our resiliency stand down will be focused on. Everything is a holistic point of view. We partner with our family programs, we partner with our chaplains. All of us work very closely together. When a soldier is touched, he's not just touched by me, but he's usually touched by every single person within the guard. I know I went through that really fast.
Questions?
Are you the only licensed person?
So I am the only licensed person that is full-time. That's 24 hours a day, 7 days a week. We have, when I showed you the M-Day status, so on the M-Day status, we have behavioral health officers. And under the behavioral health officers, we have about 5 behavioral health officers that come in like maybe once a month. And they provide like fitness for duty, those types of assessments for soldiers once a month. But I'm your full-time person.
With a caseload of 51.
Yes, ma'am.
Okay.
That's exactly how that works.
Yes.
Thank you. Yes.
How does that compare?
5,100 office
Right.
soldier. That's a lot. That's like 24/7. It's important work and really the program you've developed. But that's a lot.
It's amazing work. Sometimes I guess people are like, are you tired? But I'm not tired because I think if I ever had a job, and I know I rambled a little bit and I may have lost you, but it's a job where you get to be innovative. So when a unit calls and a unit's like, Miss D, we just got our unit risk inventory and it said the following things, like we're having a substance abuse issue. We're having, people are saying that we have issues with sexual assault, or we're having like, they don't like the way command is talking to them, I get to go sit down with the commanders and the leadership in that unit. And we come up with an entire plan that fits that unit that they get to put together. And sometimes they're creative and out of the box. I mean, like when the governor, when you were there the other day, when you left, what happened was we rolled out pieces of paper and take them to the wall, and people were writing their stress all over that paper. But ideally what happened was, now from a battle buddy status, everyone in that room knows from their left to their right how the person next to them is stressed. And so now the next time they come into work, if the person next to them feels stressed, they'll be able to say to him, hey, I remember when we were doing that stress briefing, that when you tap your feet too much, or when you bite your nails, or when you are 10 minutes late, those are signs that you're stressed. Do you need to talk to someone? Do you want to call Miss D, or do I need to reach out to someone for you? So that activity alone right there has given me, for me, a whole bunch of partners in care. And so what I do is for each unit, we put something together like that to allow for partners in care. So every unit we get to cater and be inventive and give things like that. I don't know another job where I would be able to do that.
So did any of them write down that they were stressed because the lieutenant governor said something that bothered them?
When they left, I think they were more like, oh my gosh, who gave out their business card and why didn't we think of that first?
Right.
Yes.
I have a question.
Yes, ma'am.
So the issue of trust is just huge.
Yes.
And I'm wondering, over time, what would you say, how did it evolve? How did it develop that you have the trust where, and I totally get, when you have trust, then you have partners that are helping you. It doesn't have to always be to your own. How did this develop? How did people release and let go of things like, oh, this person has a mental health issue or substance use issue, and keep them in the unit?
I'm going to tell you, it was a rocky road at first. I will give you my example of infantry. Infantry was my toughest unit. The first, they had an incident in infantry where someone had ideation, and I was called out to infantry.
Can you keep talking on the mic, because we have people.
And so I was called out to infantry to do a talk. And when I got to infantry, there was a line of people waiting for me, arms crossed, and it wasn't even the whole unit yet. And they told me right there, we are not talking to you. You're going to take our guns and you're going to take us out of uniform. And there is no way we're having this discussion. And I said, that is not my goal. And so I let the line of people who were standing there just have at me. And then I went to infantry, not just for every drill, for almost every full-time day that they were there too. And we talked and I worked with people, and it was just really putting in that daily work. Myself and Sergeant Ritter, I think we were just there all the time. They saw my face, they knew I was there. And then I gave them results. I kept my word. I gave them the results. Now, if I show up to infantry and I don't have their unit t-shirt on, there's something that they have to say about that, because Miss D, where's your unit t-shirt? And I got to say that had to be almost 2 years ago that we had that with infantry. They just came through for their PHA, and how I measure how we did was one of the doctors and the chief of behavioral health said to me, you know, it was so weird. Infantry just went through, less than 3 people needed to be seen for a behavioral health issue. I was like, yeah, isn't that cool? I was like, but we spent a lot of time with infantry. So, I mean, that was sending a 68 X-ray out to the field with them and everything, so.
So the secret sauce says, it starts with the commander.
Yes.
And, so if the commander didn't make space for her leaders to take a next step, and instead of the old model, the old school way of you just bury the stress and you lock it up and you hope that you keep a key on it for the rest of your life, which doesn't work and leads to all kinds of negative outcomes. So I wish we had Janine Burkheads in all the organizations where we have to eat the stress on behalf of our society, our public health folks, our police, our EMS, our first responders. Because a lot of us got brought up in a system where it was not a safe place to share an emotional state. So the proof's in the pudding. So you can fake it or you cannot fake it. And so I think our soldiers see a leader who leads by example. Now, don't in any way, shape, or form miss the fact that, while she is petite in size, okay, she's a combat experienced leader who is led under the most difficult of situations. But she's smart enough to know that we can only eat the stress for so long. And then after a while, it just eats away at our organizational culture. And we end up becoming the opposite of the thing we want to be the best at. So, I just, Miss D is a force of nature made possible by a leader who recognizes I've got to take care of my formation or I will lose them. This is an unpaid announcement. We're peers. We've been together in uniform for 25 years, and every time I'm around her, I learn something new. And I just think this is worth stating that if you want to change the culture of an organization, the leader's got to say it's okay to share the stresses that you deal with every day. If you don't, the old saying goes, culture eats strategy for breakfast. And so I just think it's important to recognize that she inculcates a culture of acceptance, making space for what used to have no space for. In 20 years of combat, you carry a certain amount of experiences with you forward. And she's finding a way to help our soldiers find a way to find healthy outlets for them instead of unhealthy outlets. So, as a fellow teammate, I continue to be impressed. And I wish we had a Janine Burkhead in every organization out there, because I think we'd be better for it.
Thank you, John.
I agree. So when I'm on the phone at 2 a.m. with someone, I got to say that a lot of times she's on the phone with me. So I don't disagree. I'm not on the phone alone. When I'm on the phone at 2:30 in the morning, she does not leave me alone on the phone at 2:30 in the morning trying to help a soldier. So no, she's a team player with me all the time.
Any other questions? Thank you very much.
Thank you for having me.
Thank you.
And if you want to be a community partner with us, please, by all means.
Okay, at this time, we will start taking public comments. We had one sign up, and I guess there's some people coming in virtually. Donald Reed. You can go to this mic or that mic, either one. But no, either of these two on the sides.
I apologize if I'm coming to the wrong forum. I don't understand how the commission works.
Sorry.
I read the report from the Involuntary Commitment Stakeholder Work Group late this summer, early fall, I guess it was, and had some comments on it. If I should be directing that to some subcommittee of yours, I'm happy to do that rather than give it to you here today and keep it here. But
I mean, if you want to make your comments now, that's fine. You can also submit comments, to the email address that I never remember.
I think I've got it.
Oh, okay. All right. But if you want to, make a statement, you can.
Well, I'll make it much shorter than what I wrote right here. But I'll just say that I was here to state my support for the recommendations of the Involuntary Stakeholder Work Group. I think there's some small additions that might be made to it. And I just wanted to also support the inclusion of family caregivers in that process. But as someone who's a parent of a young adult living with mental illness, who, under the guidance of some voices and sort of psychotic episode, planted a knife against the wall and impaled himself on it because the voices told him, I understand families being concerned about their family members when they become psychotic, when they have a need to get them treatment and they're not cooperating. I was lucky enough, my family was lucky enough to encounter a judge in the district court who basically coached us through the process, told us what we needed to say in order to get an emergency evaluation done. And we were lucky enough that he was retained by the hospital long enough to have that happen. I'm a volunteer, and I teach in a program called Family to Family for the National Alliance on Mental Illness. And over the last 15 years, I've probably had 400 family members in classes that I taught. And two recurring themes are always, year after year, how difficult it is to get your family member committed when they're not well, and how very difficult it is, and it gets worse every year, to get the hospital to retain them and provide effective treatment. They're released within 48 hours on so many occasions, and that's not even enough. Either they're not medicated, or it's certainly not enough time to allow the medication to work. So I'm very appreciative of the three proposals that the involuntary commitment work group made. They all represent some progress in terms of refining the dangers in the standard, adding some improvements to data collections, and concerning their training. And so I'll just save those comments for a written testimony. I'll only add a note at the end on behalf of myself and the family members that I've worked with to say, the work group's report states that it's the role of the administrative law judges and defense counsel to ensure that there is a proper balance between the patient's rights and public safety considerations. But the patient's rights and public safety are, in fact, balanced on the backs of family caregivers. We remain responsible for our ill family members until they're able to be responsible for themselves. We expend our time, our financial resources, and our health in negotiating this balance each day, and we need help. So we're very appreciative of the small steps that have been taken there in the direction of assisting family caregivers by the involuntary commitment work group, and appreciate your time today.
Thank you. And again, now I do have the email address, and that's mbh for mental behavioral health .commission@maryland.gov. mbh.commission@maryland.gov. Thank you very much. And it's, individuals and families like yourself who we, are really thinking about with this commission, and those who are suffering, but we know it falls on the families. And particularly if you have an adult family member or someone who's 18 and above, that it becomes even more difficult because, like you said, an involuntary commitment for that 18, 19, 20-year-old, a voluntary commitment of that person, they can be held for a period of time. The hospital releases them. They don't have to tell you that your son or daughter has been released who's 20 years old. And so they can walk out the front door and be who knows where. So thank you very much. Do we have any others? We had, I think Mollie Herman signed up, even though she was on the agenda. Do we have people coming in remotely? I see there are other.
Yes, I'm here remote. Nope. It's not.
Identify yourself. I can't really see. I see a David.
David Pickard?
Yes. Did you want to testify?
Yes, I would, sir. I would. May I begin for this brief testimony? Okay. Thank you guys, you folks, very much for what you're doing and allowing me to share these few words. I'm a psychiatrist. I was former chief of the experimental therapeutics branch in intramural research at NIH. I ran schizophrenia research programs and have continued my career, including taking care of a great many of patients. And the involuntary commitment is a tough thing. It's tough as a doctor to do, but it's life-saving. And this is
give us your full name.
Yes, David Pickard. I'm sorry, Pickar, MD, psychiatrist. I'd be glad to send you more information if you would like. And I'm commenting on the criticalness of being able to hospitalize somebody to save them or others or our community. Schizophrenia is a severe illness. You all know that. I'm preaching to the choir, I know. But I've lived it as a scientist and a clinician my whole life. And Maryland is a terrific state, but on the matter of dealing with seriously mentally ill patients, unfortunately, is not particularly friendly to the way I see it. The deterioration that's associated with schizophrenia that may be represented by danger at this moment or another moment in the concrete way that's required doesn't fully communicate the danger it is to these persons and to our community as this illness progresses, and particularly if it's an untreated state, which unfortunately is surprisingly common. We've heard a few moments ago from a family member, and our friends at the National Alliance have always helped that people with family members speak out and so forth. But as a clinician, it's one of the hardest things I deal with. It's hard to commit someone against their will. I don't just mean logistically hard, personally and professionally hard, but it saves lives. And if you've seen what I've seen, the deterioration of this disease, your standard of immediacy and danger to self or other, which is the case when you do it, and I can't count the number of times that I've been in a position of having to do it, doesn't fully communicate the danger at hand. That's number one. And this is a little bit at the edge of what the commission is working on, but you alluded to this. If somebody's against or held in the hospital against their will, you cannot medicate them. Maryland is one of the rare states, where if somebody's committed against their will, you cannot enforce it to take medication. It's beyond imagination. And have I lived through that? Yes. Have I seen it taken to a mental health court? Yes. I was embarrassed to be part of that court. I felt very badly for the patient, for the family, and everybody involved. There was neither expertise. The patient's entitled to hire a lawyer. It was sad and silly. So that one fact alone separates Maryland from virtually every state in the country. There are other issues as well, as many of your advocates may know, including assisted outpatient treatment. But in the matter you're dealing with today, the illness in an untreated state is dangerous. And its danger takes many representations in terms of safety of themselves as well as actions. Then all you have to do is look at the number of patients who've committed harm, and I mean serious harm, to family members and others throughout the country. We see it in the news all the time. Maryland needs to step up and help us keep our community safe, help these patients and their families. And if there's any way that you could see fit to enable when someone goes to the extreme to admit against their will, and it is a very hard thing to do, to then have somebody sit on their hands for 4 days in a psychotic state because they won't take medication is extraordinary. And I've never seen anything like it. So thanks so much for what you do. I don't mean to overstate it. I spent my life as a scientist and as a clinician helping people with serious mental illness. And just hearing this from me, I hope you take it into account the best you can. And if you could just help keep us safe and keep their patients safe and help these families in line with almost every other state. We're the outsider here. We're the outlier. So that's what I wanted to say. Be glad to take questions, but I don't know if that's how you're set up to do. And once again, I appreciate for the work that you're doing on this behalf. I really do.
Okay, thank you. I mean, we can, if there's anyone who has a question about that or a comment.
Hi, this is Dr. Jones. Yeah, I just wanted to say I'm not really sure what Dr. Picard was referring to when he says that patients cannot be medicated against their will. Patients are medicated against their will in Maryland and in Maryland hospitals if they're on an inpatient unit.
Not true. Not true.
Well, people can't. There's a medication panel process for people to be medicated against their will.
And ma'am, I participated in one of those, and I thought it was a disgrace. A disgrace. And you're admitting somebody, let me finish here. You're admitting somebody against their will to get treatment, and you're stopped from giving them treatment, and that's what the fact is. So now you have somebody who's lost their civil liberties and no treatment. In terms of that panel, in my experience, the superficiality and lack of appreciation of what they're dealing with is extraordinary. I'm sorry you're making faces at me, ma'am. I live it. I take care of these patients, and I've lived through this more times than I can count. So you're the outlier here. when you talk about families and patients who do this all the time. So it is not true. You cannot medicate somebody.
I guess it's a difference of opinion, but as someone who ran a medical inpatient unit for 7 years, we met people on a regular basis who were not compliant with their medications. I will say that the experience that people have in different environments certainly does vary depending upon the treatment team that it is that you're working with, because every treatment team is not exactly the same. So I can't speak for your experience, and I'm sorry to hear that you have had that experience, but people in the state of Maryland who are on inpatient units against their will, who are not willing to take medications, if the treatment team feels that it is critical for them to take medications for their safety, for the safety of the milieu, for the safety of the community, and also to help ensure that the person gets better so that they can be returned to a less restrictive environment, they can be medicated against their will, and they are.
Yes, I hope what you said makes it entirely clear. You take somebody, you work on the unit, get somebody against their will for safety is an enormous task. They get into the hospital and they say, I don't want to take medicine. They're not medicated. You have to, you know how many days that takes? And do you know this lack of, you can make your faces, but this is the reality that we deal with. Families all know it. And the only criteria for medication against their wills is that they're in immediate danger to hurt a staff member or themselves. Other than that, ignore the illness. Ignore it, that they're that way. So I disagree strongly with you. You're the first time I've ever heard anybody say anything positive about a medication panel. And I deal with psychiatry all the time, and I deal with these patients all the time. So to the commission, please, learn about other states. You're the outlier, and in a very bad way for the seriously mentally ill. Maryland is an outlier this way. It's extraordinary.
Look into it, but I do think it's probably, different experiences in different hospitals and different panels that, there may be some inconsistency that takes place.
I don't think,
thank you very much for your comments.
Okay, I don't think there are. Okay.
Another person coming in who wanted to make a.
Yeah, I'm done.
Okay, well, thank you all. I don't think since there's no one else. Oh,
excuse me. Lieutenant Governor Evelyn Burton had her hand up from where we sit on Zoom land.
Well, actually, I would prefer if some of the other people that have been waiting went first. Mr. I see Cornelius there had signed up, and Joanne Connors had signed up. They're on the Zoom.
Hello, everyone. My name is
Go ahead.
My name is Cornelius. I'm one of the, I work with Help in the Home, a senior care coordinator there. Our agency supports individuals with a severe mental illness in the Rockville and the DMV area. I just wanted to piggyback on Dr. Picard's comments and just share a story about one of the clients whom we serve or whom we served recently. For purposes of this testimony, I'm going to call her Cindy. She thrives so well in our supported living community, working and taking college courses. After deciding that she no longer needed her medication, she developed psychotic paranoid delusions. However, this did not meet the danger standard for involuntary hospitalization. She disappeared in the night without her belongings. So Cindy was recently found by a truck driver on a highway. She was unsure of the month and did not want to go home or to the hospital. So the trucker bought her needed clothes and food, but could not convince her to seek help. Each day, the best her parents can do, can hope for, is that their daughter is alive in a jail or hospital. The final danger definition proposed by the Mental Health Hygiene Administration is still a barrier treatment. And would not prevent someone like Cindy from becoming homeless. One, the proposed definition specifies that the danger must be recent and current, which could still be interpreted as imminent danger. Rather, it should indicate that danger is reasonably expected in the foreseeable future. 2, the proposed definition intentionally does not include psychosis as a danger to self. It requires that a person is physically decompensating to a point that is almost guaranteed to become a public or personal safety catastrophe. This definition condemns those with psychosis to continued brain deterioration and drives them into homelessness and incarceration. The definition needs to specifically include inability to meet the need for psychiatric treatment, such as to create a substantial risk for serious psychiatric deterioration. And finally, the definition should require that personal medical and psychiatric history be considered if available. And this will enable those involved to look at the entire experience of the individual, such as what happened previously when they stopped their medication, and not just the current moment as is being done now. So the changes would allow providers like us to help those who are seriously ill and refusing treatment before there are tragic consequences. And we really urge the Commission to recommend these changes to the governor and to all the other parties that are concerned and involved. Thank you all for your time.
Thank you. We will capture some of that in our minutes, but if you can submit that, your recommendations to us at the email address that I had mentioned before, mbh.commission@maryland.gov.
I will, sir.
And Connors.
Hi, thank you for letting me testify virtually. My name's Joanne Connors and I live in Montgomery County. I've got a master's degree in economics and I currently work as an IT contractor for the Internal Revenue Service. And I was diagnosed with schizophrenia 26 years ago, and it boggles my mind that we're still dealing with this issue. When I'm ill, when I'm on meds, you'd never know that I was ill. I work full time, I exercise, I do everything just like you do. However, when I'm off the meds or on an inadequate dose, I get delusional, I lose insight. Basically, I have schizophrenia, which you're all aware of. If I'm involuntarily hospitalized, medicated over objection within 24 hours, I realize again that I need the medication. But twice I had extended periods of psychosis because the current standard does not recognize psychotic deterioration and is interpreted to mean imminent danger. But it took me 1 to 2 years for me to be involuntarily hospitalized until I was a danger to myself. Both times I lost all of my savings, over $100,000, lost my job, lost my health insurance, lost custody of my son, and lost my dignity, frankly. I suffered mental anguish and made suicide attempts, something that I never would do unless this is allowed to progress to its worst stage. I had a son who was emotionally damaged from my eventual abandonment, and during the second episode, it took me breaking the law until I finally got arrested and being jailed before I served involuntary hospitalization. And this is just crazy that I have to wait until I look at it as somebody with cancer has stage 0. When I'm at stage 0 is when I need my medicine, not waiting until I get to stage 4 and I'm terminal. So denying me the treatment when psychosis first comes really puts the safety of the community at risk too, because I tend to become live in my own world with my own rules, my own laws. And once I trespassed at my son's school and wrote a letter to the principal threatening the school if they didn't get my son back to me, all just because I was delusional, which could have been avoided if when I was first hospitalized, I was given my medicine within 24 hours. So, frankly, I just never want to go through that experience again. And I actually have documents that state to anybody, to my personal healthcare advocates, that if I get ill again, to have me committed right away and to force meds on me right away, because these laws are just ridiculous and don't protect me from getting terminally ill. So basically, I just want to say that I think that this is needs to be changed, and that I like I said, I can't believe that 6 years later, we're still having this discussion, and that if I got ill again, I could end up spending 2 years running around being psychotic and breaking the law and getting thrown in jail before I could get the medical care that I needed. So thank you very much.
Oh, well, thank you. Thank you for, sharing your experience. We are looking at that. I know behavioral health is, looking at the danger standard, the involuntary commitment. And so appreciate your comments. They will be in the minutes and something that we can continue to discuss with the health professionals. So thank you. Evelyn, I know that you've signed up also. We have 6 minutes total.
Although I think Senator Eckert had a question.
Thank you very much, Lieutenant Governor. I'll put my comments in writing. They are along the line of the other spokespersons today. Our sheriff called me in a panic because we had a lady that was suicidal. She went to the ER, she was treated, she was released, and then she promptly jumped off our bridge here in Cambridge. And then I had another colleague, somebody that you all know as well as I do, report to me about a constituent whose mother was killed by her son when they were out of control and psychotic. So I'll put that in writing, get those people to do that as well. And thank you very much for the opportunity to just add my 2 cents.
Thank you. Okay, well, for the record, I'm Evelyn Burton, Advocacy Chair for Schizophrenia and Psychosis Action Alliance. And I've submitted lots of testimony on the danger standard, and you have that in writing. But today I would actually like to bring to your attention today some testimony that was sent to the commission this past week by preeminent professionals in the field of mental illness who were not able to be here today, but said I could talk about their testimony. The first one is Dr. Robert Buchanan. He writes, I am a professor of psychiatry at the Department of Psychiatry, University of Maryland School of Medicine, and director of the Maryland Psychiatric Research Center, MPRC. I'm also the director of the Maryland Early Intervention Program, EIP, which is a collaborative effort for early identification and treatment of mental illness with psychosis. I'm not going to read it all, but the main thing is he goes on to say there's considerable empirical evidence to suggest that prolonged duration of untreated psychosis, DUP, is associated with poor treatment response and worse social, emotional, and occupational outcomes. Increased DUP is also associated with increased risk of suicide and violence. 10 to 30% of suicide attempts occur prior to treatment. 15 to 20% of individuals with untreated psychosis have had some experience of violence prior to treatment, and a significant portion of homicides committed by people with illnesses with psychosis occur prior to treatment. My experiences have only reinforced the importance of early detection and identification. However, there are several important impediments to the delivery of early intervention. One of the most important is the failure of people with a mental illness with psychosis to sometimes understand the need for treatment, including hospitalization. The expansion of the standards for inpatient commitment along the lines recommended by SAMHSA would greatly facilitate early intervention with individuals with psychosis and improve long-term outcomes. And he quotes the SAMHSA recommendation, which I think is really important for the commission to look at because it was not included in the final BHA report, even though they included other recommendations, but this one was omitted, which pertains to the danger standard. It says, quote, without commitment and as a result of serious mental illness, the individual will be at significant risk in the foreseeable future of behaving in a way, actively or passively, by acts or omissions that bring harm to the person or others. Harm to the person may include injury, illness, death, or other major loss due to an inability to exercise self-control, judgment, and discretion in the conduct of his or her daily activities, or to satisfy his or her need for nourishment, personal or medical care, shelter, or self-protection and safety, and would greatly the self-protection or safety, that was the end. And then I guess I would just like to point out that some of the language in that would really clarify that we're getting rid of imminent danger, especially where it says will be at significant risk in the foreseeable future. The proposed language by BHA, includes recent circumstances and current danger. It's not clear at all like this other language. And BHA rejected language that would make clear that psychiatric deterioration is a danger, whereas the SAMHSA language talks about inability to exercise self-control, judgment, and discretion, which would cover psychosis. So I think it really needs to be looked at carefully. And I would also like to point out the testimony of Patricia Solik, who's a longtime mental provider and administrator in mental health services in Maryland County jails. She explains that the danger standard barrier to hospital treatment is a major driver of those with untreated mental illness into the criminal justice system. And she even says it prevents appropriate care of inmates in the jails. She makes suggestions on additional changes needed to the proposed BHA language to prevent the criminalization of those with mental illness. So thank you for listening, and I hope you look especially at those two testimonies very carefully.
Thank you. Did you submit those, or have you put those online?
Dr. Buchanan submitted his, and Patricia Solik also submitted hers already.
Okay. All right. Okay. Well, thank you very much. We now are at time. Thank you to all those who participated and the testimony, in particular those coming in virtually. Thank you very much. I also, the county executive has left, but I want to thank him for taking the time to address us. Of course, I want to thank General Burkhead, Ms. Bowie, and the entire team for all that they do to make sure our citizen soldiers are healthy and prosperous. I want to thank the university for hosting us here this evening. Thank you very much. Our next commission meeting will be in January 11th. It will be at the State House in Annapolis. And with that, I want to wish everyone a healthy and happy end of fall into winter and the holiday seasons. So thank you very much.
Thank you, and thank you for having
into winter.
virtual.
Okay, just want to make sure.